There have been more than 30 trials, 3,750 abstracts, so it's very difficult to summarize all those trials. But I have selected a few trials which have impact of changing your practice, and I may have left a couple of trials. So first section would be lipid and heart failure, which we generally encounter day in and day out in our practice. So Lodestar was the first important trial discussed there. Lodestar was a randomized comparison of actually two different lipid lowering strategies: a treat to target lipid lowering and a high dose statin trial. That was the original Lodestar trial. This was a secondary analysis where they compared two commonly used statins, rosuvastatin and atorvastatin. So it was basically a trial in patients of CAD, diagnosed CAD, and patients were randomized into rosuvastatin and atorvastatin. Big trial of 4,000 patients, and it was a clinically endpoint-driven trial. I think a comparison of rosuvastatin and atorvastatin, I think this is one of the probably the largest trial till date, with a long follow-up of clinical endpoints. The baseline characteristics were similar, but there was no difference in clinical endpoints between rosuvastatin and atorvastatin arm. In fact, numerically endpoints are higher with rosuvastatin, again showing that there is no difference in primary endpoint. But surprisingly, rosuvastatin had a better LDL reduction as expected and shown in previous trials, and more patients in rosuvastatin arm achieved an LDL goal less than 70. But at the same time, there was high incidence of diabetes mellitus, 29, almost 30% higher incidence of diabetes and 60% higher incidence of cataract. So this is the first large RCT comparing atorvastatin and rosuvastatin head-on. Despite a better LDL reduction, rosuvastatin did not improve clinical outcomes. Of course, there is a risk of diabetes which is higher with rosuvastatin, which we know from the beforehand. Before jumping onto high-dose statin, we need to just look at our patient's profile before. Second trial was this this ocean dose trial. So lipoprotein A is a very important marker of atherosclerotic cardiovascular disease, especially in Indian subcontinent. But till now, there is no therapy for lipoprotein A except for PCSK9, which is again injectable therapy and costly. siRNA is a different molecule. Olpasiran is a siRNA or small interfering RNA to lipoprotein A. So olpasiran enters the liver cell and combines with the RISC complex and ultimately destroys the LPA production. So ocean dose was a previously published in last AHA. This was an extended follow-up trial. That means after 36 weeks of the last dose, patients were followed to see what happens to the LPA and oxidized phospholipids. There are 4 different doses were tried, and if you look at that, this molecule can be given every 3 months or every 6 months. And if you attain a dose of 225 milligram, then you almost get 100% reduction of lipoprotein A. So this trial sought to examine the effect of olpasiran on oxidized phospholipids and effect on lipoprotein A after the drug is stopped. So there was again 100% reduction of almost 100% reduction of oxidized phospholipids. And you can see here, even if you stop the therapy, even if after stop the therapy at 36 weeks, there is a legacy effect, and you get almost 50% reduction of LPA even after 1 year of stopping the therapy. And the follow-up showed that there was no safety signals. So olpasiran is a siRNA against lipoprotein A. It is safe in long-term use, and even after stopping the drug, you have 50% reduction of LPA at 1 year. Next, coming to heart failure, we know that SGLT2 inhibitors are now class 1 indication for heart failure, both for preserved and reduced AF, whether it is empagliflozin, whether it is dapagliflozin. But use in acute heart failure is still not been studied, because we think that if you use an acute heart failure, there is a risk of hypoglycemia, ketosis, worsening renal function, genital infarction. So there was up till now no trial of dapagliflozin or empagliflozin in acute heart failure. This was so DICTATE-HF was the first trial. It was a small trial, open label trial, but it included patients with acute heart failure, and it was the primary endpoint was to see the diuretic efficiency, basically, which is calculated by dividing the weight change divided by diuretic dose. And again, if you look at the primary outcome, there was significant benefit dapagliflozin. Both weight change was higher and diuretic dose was smaller. And dapagliflozin use led to natriuresis. It led to faster transition from oral to IV to oral diuretics, early discharge, and early diuresis. And there was no safety signals of ketoacidosis or hypertension or hypoglycemia. So this is the first trial showing that dapagliflozin can be safely initiated in selected patients in acute heart failure. and its use will lead to natriuresis, diuresis. It will decrease the diuretic dose. Your patient will be discharged earlier. However, this is not a cardiovascular outcome trial. We have to wait, and you have to only use this drug in only selected patients. Second heart failure trial was semaglutide. Semaglutide is a GLP-1 receptor agonist, and generally in patients of diabetes and obesity, it has shown significant improvement in cardiovascular outcomes. We also know that heart failure with preserved EF is now a major burden across the heart failure, and many patients of HFpEF also have obesity. So STEP heart failure was the first trial to investigate the effect of subcutaneous semaglutide in patients with HFpEF with obesity. How will semaglutide work in HFpEF? There are multiple theories. It can produce weight loss. It can produce, decrease blood pressure, decrease inflammation, decrease. There are multiple mechanisms. So in this trial, I think almost 500 patients who were having BMI more than 30 and with heart failure with preserved EF were gradually up-titrated to semaglutide and followed up for almost 1 year. The primary endpoint was not a clinical endpoint, it was primarily a Kansas City Cardiomyopathy Questionnaire, clinical score, and change in body weight. There were some secondary outcomes, baseline characteristics were matched, and you can see that in the primary endpoint there was significant reduction in Kansas City Cardiomyopathy Questionnaire. Weight reduction was almost 10% higher compared to placebo. There was also improvement in 6-minute walk distance. There was also improvement in secondary endpoints and HSCRP. Safety, generally only GI side effects were there, otherwise there was no safety signals. So semaglutide is again a new class of drug, and in HFpEF patient it has shown that it can improve quality of life, decrease inflammation, decrease body weight, and lead to improvement. However, again this is not a cardiovascular outcome trial. Coming to antiplatelet and anticoagulation trials, we have got a host of trials. Now generally elderly patients and frail patients do have atrial fibrillation, and we fear that if we give VK or continuing VK in such patients or vitamin K antagonist can increase bleeding. So is it good to switch from vitamin K antagonist to a NOAC in elderly frail patients? That was the research question of the FRAIL-AF trial. So OPD patients who had frailty index, elderly, and patients were on vitamin K antagonist for all AF were included, and the primary endpoint was safety. Now we know from the NOAC trials that NOACs decrease bleeding compared to VK by 50%. That's why we thought that if we switch from VK to NOAC, probably bleeding will be less and probably patients will improve better, because you don't need to measure the PTNI. There are no food interactions, there are no drug interactions with NOAC. So we thought that if we change VK to NOAC, probably patients will benefit better. These are the definitions of bleeding. However, contrary to the expectation, switching from VK to NOAC led to higher bleeding in elderly frail patients. And the only issue is that the major NOAC switch was with rivaroxaban, and we know that among NOACs, rivaroxaban is not the best for bleeding. Probably apixaban and edoxaban produce a less bleeding. But still, switching from VK to NOAC produced more bleeding, and there were also more thromboembolic events. So in patients, elderly patients who are already on NOAC, already on VK, do not switch to NOAC unless they have a clinically encountered bleeding or they have some problem with VK. After doing, and then there was the right trial. After doing primary PCI, sometimes because of high thrombus burden or other indications, people try to write post-procedural anticoagulation. Generally, we don't do that, but this study show that across the globe, people keep on writing heparin or bivalodin or unfractionated heparin after primary PCI. So right trial was a trial to see should we use a prolonged anticoagulation after successful primary PCI. And there were 3 groups: unfractionated heparin group, enoxaparin and bivalodin group, or there was a no anticoagulation group. And there was a primary safety and bleeding endpoint. There was no benefit in continuing oral anticoagulation, parenteral anticoagulation after primary PCI, and there was no improvement in safety or bleeding. However, if you look at the enoxaparin arm, probably there is some hint of benefit. So routine use of post-procedural anticoagulation in primary PCI is not needed. However, further data needs to be seen whether enoxaparin in low doses can be used in such situation. Stop depth 3. Generally, there is a confusion what to use, whether to use dual antiplatelet therapy after PCI, what is the duration, how long, which antiplatelet to be used. So STOP-DAP trial was a trial in elderly Japanese patient where after PCI they switched straight away to single antiplatelet therapy. Normally trials show that you should give dual antiplatelet therapy after PCI for 1 month, 2 months, 3 months, and then switch to SAPT, like Twilight, Tycho. But in stopped at 3, immediately after PCI, they randomized the patients into 2 different arms, DAPT with aspirin and prasugrel monotherapy. Elderly patients, the age you can see is around 71%, and these were the inclusion criteria. And it was seen that the bleeding was significantly reduced with prasugrel therapy, monotherapy. However, cardiovascular events were increased with prasugrel monotherapy. Stent thrombosis was increased and unplanned coronary revascularization was increased. So this results of this trial say that dual antiplatelet therapy still should be the standard after PCI, and immediately switching to a single antiplatelet therapy does not help. Maybe you should wait for 1 month or 3 months. So dual antiplatelet therapy with aspirin and epitol inhibitor is the standard of care. Nowadays, many of us are using smartwatches, and many of our patients have implanted pacemakers, ICDs, CRTs. Now, those machines have a tendency to detect atrial high rate episodes or subclinical AF. What should you do if your pacemaker patient of your smartwatch shows atrial fibrillation whereas the surface ECG does not show? So such patients called as atrial high rate episodes, should we anticoagulate or not? That was a NOAA F6 trial. So this is a patient of pacemaker showing that surface ECG is normal, but at some times the pacemaker machine has detected atrial fibrillation. So what to do with such subclinical AF? Should we anticoagulate or should we not? So that was a NOAA F6 trial where patients with subclinical AF or device detected AF or atrial high rate episodes were randomized to anticoagulation or no anticoagulation. And the Chadwick risk score was, clinical risk factors of AF were there, and the Chadwick was high, but there was no AF on surface ECG. The trial was terminated early due to futility. There was no benefit in giving anticoagulation to patients whose surface ECG is normal but the device is showing AF. In none of the subgroups there was benefit. In fact, there was more bleeding. So in patients without a surface ECG showing an atrial fibrillation, you should not give anticoagulation. Coming to some coronary intervention and imaging trials. So FIRE trial was the first trial I was talking about, multivessel disease in STEMI. So as Dr. Rohit said, that multivessel disease in STEMI is a challenge. Now this is specifically a subpopulation of elderly patients age above 75, and the FIRE trial tried to see whether we should do a multivessel PCI or we should do a single vessel or culprit only PCI. So elderly patients with multivessel disease were enrolled, and left vein unclear culprit lesion prior CVG were excluded. Patients were randomized into culprit only revascularization and physiology guided revascularization, which again Dr. Rohit assessed. And what were the physiology used? FFR, IFR and QFR. And we are happy to share that the stent used was an Indian stent made by Shahjahan Medical, the Supraflex Cruise. And there were hard clinical endpoints of death, MI and stroke. At the end of 1 year, there was almost 27% reduction in primary endpoint of cardiovascular death, MI and revascularization. Secondary endpoints of death, cardiovascular death and MI were also improved, and there was no safety signal. So FIRE trial says that in selected elderly patients with acute MI, if you do a physiology guided revascularization, then there is improvement in cardiovascular outcomes. Second trial is multi-star CMI. Again, this is all comers, same population, STEMI with multivessel disease, but here it's not specifically elderly population. And here patients were randomized to immediate PCI. That means you do all the vessels in the same setting, or you stage it between 2 and 6 weeks. Again, it was a primary endpoint was all cause deaths, fatal MI, stroke, etc. And the patient excluded these high risk cases as we were discussing. There was low representation of diabetes in this trial. And as you can see that if you do an immediate PCI of all vessels, then the hospital stay is reduced. The contrast use is reduced, the fluoroscopy time is reduced, and there was also improvement in clinical outcomes. So immediate treatment of all was non-inferior to staged multivessel PCI in this trial. And last was the OCT trial, Illumin trial. Now OCT we have been using for multiple years, but there is still not any data to show whether it can impact cardiovascular outcomes. So Illumin 4 was done with a primary endpoint to see that can it improve clinical outcomes, and in these high risk patients OCT was done, and these were the endpoints. So there was significant improvement in final mean stent area. There was improvement in lesser dissection, lesser malapposition. However, there was no improvement in clinical endpoints. The target vessel failure was not different between the two arms. Stent thrombosis, of course, was lower with OCT arm, and there were numerical trends towards lower avoidance. So if you use OCT in your patients, you can expect good procedural outcomes. Overall cardiovascular outcomes will not be affected, but you can expect a decrease in stent thrombosis. And last is the Valor SCM trial. It's already been presented last year, but this was a long-term extension of this mavacamten, which is a first-in-class myosin inhibitor. And this was an extended trial up to 56 weeks. And it included patients of HCM who were referred for septal reduction therapy, which is generally not possible. So this drug showed that if you continue mavacamten, then your referral to septal reduction therapy is reduced, your NOHA class improves, your elevated gradient improves, your BNP improves, your troponin improves, and all echocardiograph parameters improves. But the only problem with this drug is that it can reduce your ejection fraction. So you have to be very, very careful, and it should use only in selected population. So to summarize, Lodestar trial says that rosuvastatin would not improve cardiovascular outcomes compared to atorvastatin despite the risk of better LDL reduction. Ocean Dose says that olpasiran reduces robust LPA and oxidized phospholipids. Dictate HF says that you can safely initiate dapagliflozin in acute heart failure. STEP heart failure says that semaglutide can be a game changer in HFpEF, but we need to wait for the CVOT outcomes. In FRAIL-AF, there is no need to switch from VK to NOAC in elderly frail patients. There is no need to routinely use anticoagulation after primary PCI. STOP-DAP3 says that dual antiplatelet therapy still should be the standard of care. NOAA-FNET says that you do not need to anticoagulate subclinical AF or device AF. FIRE trial says that in elderly patients, in selected elderly patients, you can go for a physiology guided complete revascularization. Multistar AMI says that complete revascularization at Index Hospital is possible and is safe. Of course, it's a personal judgment. Illumin says that if you use an OCT, your stent thrombosis can come down. And Valor HCM long-term says that mavacamten improves echocardiogram outcomes. Now you have been listening to me for the last 20-30 minutes. Did you do it right? Was it worth it? Anyone who stops learning becomes old, whether it is he's 20 or whether he's 80. Anyone who keeps learning stays in. So keep learning and stay here. Thank you.
Great talk by Dr. Prdhan. If any question or suggestion, please ask.
Very nice presentation, Dr. Akshay. I have a question. The trial which showed high atrial rate episodes,
Yes.
Did they took into account the load of the atrial burden? Like
Yes. So patients who had a heart rate more than 200 and more than 7 hours of atrial high rate episodes, that was a predefined criteria. But unfortunately, in the trial, even with such high subclinical AF, the event rate was very, very low. So we know that when the event rate is low, then the bleeding of NOAC or VK would be definitely higher than stroke prevention. So that was the major problem, and probably COVID did a harm on many of these trials. Because of COVID, many of these trials had lower enrollment and they failed to meet their primary endpoints.
So what are the criteria they take up for detecting AF in the device?
So if you have a pacemaker or if you have a CRT,
What are the
So-
potential criteria?
so any heart rate more than 170, right? Because your pacemaker is in ventricle. Generally, it's a single chamber pacemaker, even it's a dual chamber, and the burden of atrial fibrillation is more than 7 hours per day.
What was the atrial potential?
What was the?
Atrial depolarization potential.
No, but you are only concerned about atrial high rate episodes,
Yes.
not potentials. So you are wearing smartwatch. If your smartwatch says that you are having atrial fibrillation, it's a device detected AF. Whatever algorithm you use. For pacemakers, we have implanted leads, but in these smartwatches generally use an algorithm, irregularity or potential algorithm.
So it is a single chamber pacing or double chamber?
Generally, you need double chamber or CRT.
Double chamber
Double chamber CRT.
Actual lead is receiving the signal from the
Yeah,
atrium.
yeah.
So what are the potential of average actual filtration potential of the LA P wave, you can call it.
Generally, when we plant a dual chamber pacemaker, we accept any P wave more than 2.5 for sensitive level. Pacing generally,
I think that this difference of this P wave detected through the device and detected the surface ECG, that is two different things. And probably that has not created the total statistic stasis in the atria, because some of the contraction because is there, and atrial thrombosis leads to be very long-term SSC. That may be the reason.
that is the main reason, because those patients are low event rate, because the burden has to be significantly higher.
वो हो सकता है, मगर डिटेक्शन कैसे अलग होगा? डिटेक्शन का अलग किसी से होगा?
I think Dr. Asutosh is electrophysiologist. Later on, he will clarify you.